This week, I'm continuing my discussion following the inquest report on the tragic, potentially preventable asthma death of a 10-year-old boy. I described the inquest findings in podcast number 50 and then again in podcast 51, made recommendations for a major change in the primary care approach to management of asthma. So I'm now going to talk about some practical ways that general practices can reduce the suffering experienced by people with asthma and also reduce asthma attacks and deaths, with the added benefit of reducing workload for doctors working in primary and secondary care. While this episode is intended primarily for primary care doctors and staff, people with asthma will also find this information useful. So before I continue, if you find these podcasts helpful, please click on the follow button so you'll get a reminder whenever a new episode is published. Okay, so as a reminder, when a coroner finds in an inquest that someone's death could have been prevented, and this of course applies to the United Kingdom, they issue a Regulation 28 report detailing the findings of the inquest with the aim of ensuring changes are made to prevent future deaths. Now, these reports are published on the Chief Coroner's website, so they are in the public domain. In my experience, Regulation 28 reports on potentially preventable asthma deaths don't usually result in national action or recommendations for change that are implemented. The recent inquest findings in the Regulation 28 report on the boy I spoke about in episode 50 provided evidence that risk factors for future asthma death were not recognised and did not result in escalation of care by referral to a specialist. These risk factors included excess short-acting reliever and insufficient inhaled corticosteroid prescriptions. Now, we've known about both of these risk factors for many years, and these were again highlighted in the UK National Review of Asthma Deaths, which was published in 2014 on World Asthma Day. So in episode 51, I suggested a 7-step approach primarily for general practitioners working in primary care, which could be implemented in the first instance. Now, in essence, every single doctor or nurse with responsibility for caring for patients need to ensure that they're up to date with the current evidence for the management of asthma, which is the commonest chronic childhood disease and one of the commonest adult diseases. And then we need to recognize and acknowledge that an asthma attack is a clear signal that our treatment is not working. In effect, an asthma attack is a significant event that requires action to prevent another one that may be a lot worse and could in fact lead to hospital admission or death. So general practices need a system for assessing these significant events, that is, each and every acute asthma attack suffered by their patients. I have described the process in the 7-step plan in the web link in the description for this episode, and this involves extracting information from the medical record within a week of those who've had an attack. Of course, that means that those people who have had asthma attacks need to be identified and ideally be coded as such in the medical record. Then the information is discussed with an action plan in a practice meeting. And today I'm going to talk about some of the preventable factors that will be identified and suggest some ways that doctors can deal with these. I will continue in the next few podcasts with more of these risk factors and suggestions for dealing with them. So some of the potentially modifiable factors which are identified in many people who've had attacks include, firstly, excess short-acting beta-2 agonist bronchodilators, the short-acting blue inhalers, which are so-called SABAs. The second modifiable factor involves the preventer drugs, also called controllers, and the third relates to the ability of the person to use their inhaler device, and fourth is when somebody keeps attending the general practice surgery or hospital with attacks. all of these preventable factors need to be dealt with, ideally as soon as they are recognized, and that means that an attempt needs to be made soon after someone has had an attack to identify these modifiable factors. So once these risk factors are identified, how can a general practice deal with these both as a matter of urgency for the person themselves and then by modifying practice policy? I'm going to discuss one of these today, and we'll come back to others in future episodes. So I'm going to discuss in detail in this episode of the podcast the matter related to excess prescriptions for the short-acting beta-agonist reliever bronchodilators. Now these are salbutamol or terbutaline or albuterol, and they're usually blue inhalers. So how many inhalers a year are too many or constitute excess prescriptions? Now from research, we know that 3 or more inhalers a year are linked with increased risk of asthma attacks and increased use of unscheduled care. That is, hospital attendance, emergency department attendance, or attending a general practice surgery with an acute asthma flare-up. So if someone is being prescribed more than 3 blue inhalers a year, a key question is whether these are being used for symptoms, and therefore, is the person's asthma out of control? So most asthma guidelines state that anyone using 4 or more puffs of this reliever inhaler a week has poorly controlled asthma, and that is current poorly controlled asthma. I've spoken in the past about asthma control being assessed in 2 domains, and that's current symptoms and also risk of future events, which includes attacks. So even if someone doesn't have symptoms today, if they've had an attack in the last year, they have got poorly controlled asthma. Okay, so if someone's using 4 or more puffs of their reliever inhaler a week, that's equivalent to about 1 inhaler which contains 200 doses. So it follows that anyone using more than 1 short-acting reliever inhaler a year has poorly controlled asthma. So that person's asthma is out of control, and they need to be seen, preferably in person, by someone trained in asthma care. In addition, it's now widely accepted on the basis of research that no one with asthma should be prescribed monotherapy with a blue SABA reliever without an inhaled corticosteroid inhaler. So having identified that someone is being prescribed excess reliever inhalers, that's more than 3 a year, what can be done for that person? Firstly, has the person been prescribed an inhaled corticosteroid preventer? And are sufficient inhalers being prescribed and collected, and is it being taken correctly? Remember that these short-acting reliever inhalers do not actually treat the underlying inflammation due to asthma. So a possible approach for this patient could be, depending on their severity and availability of medication in the locality where you work, the inhaled corticosteroid may be delivered either regularly or as needed when they have symptoms. According to the Global Initiative on Asthma, that's the international group that produces guidance documents for asthma based on evidence, the preferred option for delivering inhaled corticosteroid is in one of 2 ways. Either as needed in the form of a 2-in-1 inhaler containing an inhaled corticosteroid and a quick-acting, long-acting bronchodilator called formoterol. The as-needed approach applies in people who have mild asthma or who are having very infrequent symptoms. For people with moderate or more severe asthma, the preferred option is to deliver the 2-in-1 inhaler regularly, once or twice a day, and to use the same inhaler for relief of symptoms. So the person will get a reliever, which is quick-acting, and at the same time they get an inhaled corticosteroid, which deals with the underlying inflammation due to asthma. The alternative, non-preferred approach, according to Gina, is to use an inhaled corticosteroid with a short-acting bronchodilator, that's the blue bronchodilator, when needed. And the risk here is that the person will only use the blue inhaler, and therefore they will not be taking an inhaled corticosteroid. So if you're sure that your patient will take both those inhalers, then this is an option. There's another way of delivering inhaled corticosteroid regularly, and that's in combination with a different kind of long-acting bronchodilator, which is not rapid-acting. And in these people, they will also need a blue reliever inhaler to relieve symptoms when they come. And as I said, this is the non-preferred approach by GINA because there is the risk, which is the case in many people, that they will not comply and take both medications. The use of the 2-in-1 inhaler with inhaled corticosteroid and a quick-acting, long-acting bronchodilator called formoterol is the so-called AIR therapy. It's anti-inflammatory reliever therapy, which was described in detail in my podcast interview number 34 with Professor Richard Beasley from New Zealand. So the anti-inflammatory reliever therapy can either be used as needed in people with mild asthma or regularly with the same inhaler for relief, which is called MART therapy or maintenance and reliever therapy. The as-needed anti-inflammatory reliever therapy is now being used in 48 countries, including the United Kingdom, where it has now been included in local guidelines in a number of the integrated care boards in the United Kingdom, including Oxfordshire and Buckinghamshire, which are using a system very similar to that being used in New Zealand. The advantage of air therapy is obviously that we will reduce the number of people who are prescribed monotherapy with a short-acting bronchodilator blue inhaler, which will have advantages for both patients and also doctors who will find that their workload will probably reduce. Okay, so those are some of the ideas that could be helpful in improving an individual patient's asthma control. So what steps can the practice take to help deal with and eradicate the monotherapy use of these short-acting bronchodilators in the management of asthma? In my view, the first step is to remove this drug from repeat prescriptions, which can be ordered by patients without a consultation. In that way, patients will not be able to order more than 1 or 2 inhalers a year without someone reviewing their asthma control at the time that they're requesting reliever medication. As I said, anyone with asthma needing 4 or more puffs of their reliever a week has poorly controlled asthma. And I know that colleagues have said removing the blue relievers from repeat prescriptions is dangerous because they're worried that the process would prevent someone from having emergency medication. Now, there's no reason why a practice couldn't issue 1 inhaler when somebody needs it in an urgent situation and arrange an appointment or perhaps a face-to-face consultation there and then for the person to be assessed. So for those colleagues in primary care who are reluctant to remove short-acting beta agonists from repeat prescriptions, is that there is very good evidence that people using excess short-acting bronchodilator inhalers, especially without a preventer, is actually dangerous. So this is a safety measure by removing those inhalers from repeat prescriptions. And we know that excess use may result in an attack or death due to uncontrolled asthma. The issue, of course, being that asthma is an inflammatory disease and the short-acting beta agonist bronchodilators do not treat the inflammation due to asthma. So in my view, everyone with asthma should have reliever medication available, and if that reliever is one of the blue short-acting agonist bronchodilators, they should have one available for this purpose, but they should not be collecting these regularly from the practice without a consultation. So the first change for a practice is to remove the blue SABA reliever inhalers from repeat prescriptions, which could be accessed without a consultation with a doctor or asthma-trained nurse or asthma-trained pharmacist. Now, the second change for a practice that I'd recommend is to ensure that staff are trained to be alerted to ensure that anyone requesting one of these short-acting relievers is spoken to or preferably seen face-to-face by a doctor or an asthma-trained nurse or pharmacist. The reason for this suggestion is because someone relieving a reliever inhaler may be having an asthma attack, and therefore by assessing the person, finding out whether they have any features of an asthma flare-up of an attack, and importantly, whether they've been using their inhaler and whether it's been providing any relief or not. If they're not responding to the blue reliever, or they're needing to repeat its use within 4 hours, these are signals that this may be a severe attack, either in evolution or already happening, which requires urgent action. So in summary, in this podcast, I've started discussing systematic ways that general practices can change the way that asthma is managed in order to improve the lives of people with asthma and also to reduce future attacks, which will reduce general practice and hospital workload. I've shared some ideas for dealing with one of the modifiable risk factors, probably one of the most important risk factors, that is excess prescribing of short-acting beta-agonist bronchodilator reliever inhalers, the ones that are usually blue. So first, regarding management of those who've had attacks, who've been prescribed 3 or more blue inhalers in the previous year, I've suggested 2 actions. The first is to establish whether the person is actually using excess reliever, i.e. more than 4 puffs a week. And next, I've suggested establishing whether the person has been prescribed an inhaled corticosteroid and that they're collecting sufficient prescriptions or that sufficient prescriptions are being issued according to the way that it was initially intended. There are a number of ways that inhaled corticosteroids can be prescribed, and I discussed these. The main point being that according to international guidance, all people with asthma should be prescribed an inhaled corticosteroid either regularly or as needed in combination with a quick-acting, long-acting reliever called formoterol. I then recommended 2 actions for the practice to implement throughout the practice. These are first, to remove the short-acting beta-agonist bronchodilators from repeat prescription without a consultation, and second, to ensure that anyone requesting a short-acting reliever is either spoken to or preferably seen as a matter of urgency by a doctor or an asthma-trained nurse or pharmacist. In future podcasts, I'll discuss ways of dealing practically with other potentially preventable or modifiable risk factors for poor asthma outcome.